We're going to look at the role of physical medicine rehabilitation and neuromuscular care. This is a really important issue. PM&R, as it's also known, plays a critical role in maintaining optimal care. So these physicians work very closely with neurologists, PTs, OTs, a variety of healthcare experts. And Rachel's going to be leading the discussion, and I am now going to officially kick it off to her to start. We have a great panel of people. We have Dr. Sue Apkon, we have Dr. Julie Parsons, and physical therapist Terri, all from Children's Hospital, Colorado. Rachel, please take it away.
Great. Thanks, Ryan. And thank you to the team from Children's Hospital, Colorado for joining us today. I think this is a really great conversation to have. I know across the country, certain centers are primarily led by neurology, while other centers have a really strong physical medicine presence. And I think something that's really unique about the Colorado team to start us off today is the wonderful collaboration that we see amongst disciplines and how they provide Duchenne care. So I'm really looking forward to this conversation. And at this point, I'll go ahead and turn it over to the Colorado team to share a little bit of information with us about how they provide Duchenne care in a collaborative model.
Hi, thanks, Rachel. Thanks also to Ryan and Eric for that introduction, hosting today's event, and most importantly, for giving us an opportunity to highlight physical medicine and rehabilitation as a medical specialty. It is involved with the care of boys and men with Duchenne and Becker muscular dystrophy. Our specialty goes by many different names: physiatry, physiatry, PM&R, rehabilitation medicine, or just for short, rehab. The goal of a rehab physician, like myself, is to enhance or restore function in people with physical impairments or disabilities. My ultimate goal is to be able to positively impact a person's quality of life. Our residency training after medical school focuses on the interplay between the medical diagnoses and the impact on function. And as a rehab physician, the treatment tools that we think about include medicines, therapy, braces, and equipment, all with the goal of maximizing a person's abilities. As a rehab physician, I'm also monitoring the orthopedic manifestations of a disease or a condition and refer on to a surgeon when appropriate. Depending on the patient that is in front of me, I may recommend some or all of these interventions. It is very common that a rehab physician will work with other team members to develop a treatment plan for a patient. The muscular dystrophy clinic is the setting where you will see this collaboration in action. Next slide. Children's Hospital Colorado has had a comprehensive muscle clinic for over 40 years. Dr. Dennis Matthews, a rehab physician, and Rick Finkel, a child neurologist, two people that many of you know, started this clinic in recognition that boys with Duchenne and Becker need professionals from many specialties thinking about them from different angles. Terri, a physical therapist, and Dr. Julie Parsons, a neurologist, joined the team over 30 years ago. You'll meet them today as we talk about how PT, child neurology, and rehab medicine work together to provide the highest level of care to children and men with Duchenne. I'm the relative newcomer with only 20 years under my belt. Next slide. I also want to recognize the amazing group of providers from our team at Children's Colorado that you will not have the opportunity to hear from today. In addition to PT, neurology, and rehab, families and kids in our clinic will meet specialists from nursing, pulmonary medicine, nutrition, genetics, cardiology, social work, respiratory therapy, endocrinology, and psychology. It's a large team with a lot of passion and expertise to share with you. I'd like to now introduce you to my two colleagues, Terri and Dr. Julie Parsons. They'll be sharing their background and role in our muscle clinic. We'll then talk about how our team as a team of therapists, neurologists, and rehab providers, we work together to deliver the best care to our patients. So Terri, you want to take it away?
Okay, thank you. So first, thank you to PPMD for allowing us to have this opportunity. And I have to just give one shout out to our team because we've worked together for a really long time, we kind of know each other's rhythms, and we don't even have to tell each other what we're thinking a lot of times. So because of that, I feel like we move together as a unit, and that's, hopefully we'll move together as a unit today. I'm a little frazzled because I had some technical difficulties, but we'll try to go on. So I'm going to talk a little bit about physical therapy, what physical therapy is, which all of you, I'm going to guess, have a better idea about this discipline than anything else that you might, any other of the disciplines involved in the team, either because your child, your son, is getting physical therapy, or perhaps you or someone you know or in your family has received physical therapy in the past. This is an evolving field. When I graduated from physical therapy school, it was an undergraduate degree, and now it's actually a doctorate level program. So we've come a long ways, and but I think it's still the experience that we have in actually seeing and treating patients that is the most important. Dr. Apkon and I work closely together, and she explained a lot of what she's doing, which is very similar to what we do. As physical therapists, we evaluate each patient for looking at their function, looking at strength, joint mobility, pain, energy conservation. And based on that, we then try to make a plan, a set of goals and plans that might involve exercise. It might involve pain management. It might involve energy conservation, any of those things that we try to set up as goals for each patient to allow them, as Dr. Apkon said so nicely, to achieve their highest level of independence and capabilities possible. We want to try to enhance the quality of life for each of the patients that we see. And that's certainly true for the patients that we see in the neuromuscular clinic. We, like all aspects of medicine now, are looking into more evidence-based practice. We, as a pediatric physical therapist, we weren't very good at this in the beginning, but we are evolving and we're getting better at that. So we now are trying to make sure that we have good reasons for making the recommendations that we do. And again, and we're looking way more into research. When I started as a physical therapist, we weren't doing a lot of research, and now we're really involved, and that's a really exciting part of my job and part of the clinic team, which we'll talk a little bit more about what each of us does in our role in the clinic in a little bit. But right now I'm going to turn my microphone over to Dr. Parsons to talk more about what neurology does in the clinic.
Thanks, Terri. So I am a pediatric neurologist, and as Rachel said, depending on where you live in the country, there will usually be a neurologist that's involved in your clinic, sometimes an adult neurologist and taking care of mostly adults, sometimes a child neurologist. But our background for neurology is that after medical school, we become a pediatrician and train in pediatrics, and then do a neurology residency. And so in my case, a year of adult neurology, 2 years of pediatrics neurology, and then after becoming a neurologist who can take care of both children and adults, but I specialize in children, we do a neuromuscular fellowship to learn more about neuromuscular disease. So a neurologist in general will focus on diagnosis and medical management. As Sue said, we work very closely together, and a lot of times we overlap in terms of our roles. But diagnosis, I think, is and localization of where a particular medical problem is important. I think in many of the teams that the neurologist may be a little bit more like the neuromuscular primary care captain to try to help coordinate all of the various services. We also do, as Terri said, run a lot of clinical trials. And so neurology is very involved in being principal investigator in the clinical trials. Dr. Apkon is a principal investigator as well. So we share that role also. But historically, I think the neurologists have been the ones that have run the trials. In addition, because we have a lot of overlap in terms of our roles, we have elected to have neurology manage medications. So we manage the steroids, we manage the exon skipping drugs, and take care of those sort of medical issues as well. In addition, because we're also focused more on the brain and cognition, we also tend to really try to evaluate neurocognitive function in patients with dystrophin issues in both the boys and the young adults. In Colorado, because we're a freestanding children's hospital, we are able to transition older patients into our wonderful clinic at the university which is more adult-based. So we do have that ability as well. But in general, that's what we do as a neurologist, as a pediatric neurologist.
Great. Thanks, Julie. Thanks, Julie and Terri. What I wanted to do now is just for the people listening to give them a sense of what we do day to day. We have our clinics generally on Fridays, and we meet in the morning and we talk about all the kids, and then we spread out and we take care of the kids. But while we are doing that, we're constantly collaborating and talking. And so, Terri, I would love you to just to share a couple of your thoughts in terms of how you and I, as a PT and a rehab physician, work together in the clinic setting.
So fortunately, Dr. Parsons and I do work closely together. We usually go in to see the patients together. I do functional outcome measures, which those of you that go to a PPMD clinic, you'll know that we're looking at the same types of things that we look at in clinical trials. We're looking at North Star evaluations, we're looking at time function studies, and we're looking at equipment, range of motion. And then based on that information, luckily, there have been some really nice natural history studies done by the Synergy Group and several others that we are now able to predict, based on natural history studies, when your child is in a stable phase, whether or not if they're getting up from the floor in less than 5 seconds, that might mean that they're in a stable phase, and we feel good about that. If their times are showing us that your child might be ready to transition into more of a sitting position in the next 6 to 12 months, that is really important information that we have been able to get through those natural history studies. And because of that, I can pass that on to Dr. Apkon, and I can pass that information on to Dr. Parsons to be able to make decisions based make decisions that might impact whether or not they're a candidate for a clinical trial, whether or not they're a candidate for medication, whether it's time to start steroids, whether their dose of steroids needs to be increased. So based on the functional outcomes that I do, we collaborate with each other to try to develop the best plan for each child.
Yeah, and I think that, Terri, that it's absolutely true that we do end up sharing information constantly. It's been a little bit more challenging during the COVID era with the social distancing, having our patients be far apart and having us be far apart, because we're used to interacting constantly in terms of talking about the patients. But I think that particularly looking at clinical trial readiness and evaluation has been really important, and sometimes going in together and trying to solve certain problems that patients are having is also one of the roles that we try to focus on and share. Again, our clinic is a little bit different because we are a pediatric clinic and we are geographically located in a huge region. So our patients in Colorado really do come from Montana, Wyoming, Kansas, Nebraska, New Mexico, a little bit from Utah. So the catchment area that we have is huge. And one of the reasons that we set the clinic up so long ago to cover the Rocky Mountain region is because there weren't a lot of specialists that were located in these areas. For instance, Wyoming does not have a child neurologist. And so if we were able to then provide care to all of these patients, that was a huge advantage. Many of you will live in other situations where you perhaps are in a city where maybe there are a couple of different clinics, or you have an orthopedist who's in charge of your clinic, or a physiatrist who's in charge of your clinic. So we're very, very happy that we are practicing in our particular situation, but certainly there are a variety of different ways to do this. We're just grateful that we have the facility to be able to communicate. I can make a diagnosis and I can hear about a problem in a patient, but sometimes functionally I don't know how to help them. And that's where if I speak with Sue or Terri, we can usually problem solve a situation for a young adult or for a child. Sue, what do you think?
What a great collaboration that we see between your team. I think it's just so interesting to see how you all flex and really just come together to meet that common patient need, and really just capitalize off of each of your unique perspectives on the care of Duchenne. So thank you so much to the team at Children's Hospital Colorado. Ryan, Eric, we're going to toss it back to you.
Thank you so much, Rachel, and thank you, Dr. Apkon, Parsons, and Terri. It's just an incredible team, and I think, they highlighted this collaborative approach. It's something we were advocating for so long ago, even before there were care standards, that you needed a team of doctors, but you needed them communicating and working with each other, and I think they showed that and illustrated that just in what they were discussing, this sort of holistic approach to Duchenne and medicine, would you say?
Yeah, no, definitely. I mean, that's a lot of the onus of how we got to the now 29 certified Duchenne care centers that we have across the United States. Yeah. And it was exciting, too, to hear, as they talk about kind of their role in research. When we think about who is responsible for capturing some of that really critical functional outcome measure data that we need for our pivotal phase 3 trials, that comes down to our physical therapists often. Yeah. They're the ones doing that.
Yeah. Yeah, and this evolution into research now, it's really a continuum. It's care into research. Because the landscape is changing so much for Duchenne, and that's the good news. So, next up, we have the team from Seattle Children's Hospital. Dr. Omura, Dr. Perlman, and Leslie Vogel are joining Rachel right now. I'm going to kick it to Rachel to start off this conversation.
Great. Thanks so much, Eric and Ryan. I'm really excited to have the team from Seattle Children's here with us to continue this conversation about the integration and multidisciplinary care of Duchenne with rehab, neuro, and PT. I think that this is another great example of a really cohesive unit that's able to work together, is this single unit to take care of our patients with Duchenne. And interestingly enough, this is a team that previously was under primary leadership of rehab and has since shifted to neuro, being previously under Dr. Apkon's leadership. So there's that sort of 3 degrees of separation there, maybe just 1 degree. Anyway, really excited to hear from this group. Another great example who can, I think, teach us quite a few lessons about the integration of these different disciplines. So at this point, I look forward to hearing from our team at Seattle. Seth?
I'll actually turn it over to Jacqueline. I think she was going to get started kind of introducing everybody to our current clinic model and how things are structured for us.
Awesome. Thank you. And thank you, Rachel, for the great introductions, Ryan and Eric as well. I think we're all grateful to have this opportunity to be partnering with Children's Colorado and talking about this. Rachel, as you rightfully called out, Dr. Apkon was previously at Seattle Children's and was my personal mentor, in fact. So you may hear some overlap in terms of what our teams have to say, but I think that just really highlights that collaborative piece that everyone has mentioned, which is super important in the care of these boys and young men with Duchenne and Becker muscular dystrophy. Next slide, please. So we're going to kind of be going over some introductions of who we are, giving an overview of our clinic structure, and talking about our care model and how this works for us. If you could advance the slide, please. And next one. So as Dr. Apkon mentioned, physiatry has many names: physiatry, physical medicine and rehab, rehabilitation medicine, or just plain rehab. And going and looking sort of at our Academy of Physical Medicine and Rehab and what our goals are in general as physiatrists, it really is what Dr. Apkon mentioned, really to take care of preventing, diagnosing, treatment, and rehabilitation of disorders that may produce temporary or permanent functional impairment. The thing that I think is really cool about rehab is we're not necessarily focused on one body part, like a cardiologist takes care of the heart and a pulmonologist takes care of the lungs. We're really focused on patient-centered care and maximizing independence and mobility with the goal of really getting our patients participating in things they want to participate in with their families, in their communities, and in the social setting, of course, outside of the time of COVID-19, which looks very different for everyone right now. As we talk about our training, there's a couple of different ways that a rehab doctor may be involved in children or adults with neuromuscular care. Most rehab providers do 1 intern year of medicine and then a 3-year rehabilitation medicine residency. In order to practice pediatric rehabilitation medicine, there is a fellowship that is specific to taking care of children with disabilities. For some of the adult rehab providers you may see, they may have done a neuromuscular medicine fellowship, much like the neurologists do as well, but coming from a different background. So there is that possibility too. And again, my role is really thinking about function, quality of life, musculoskeletal concerns or orthopedic concerns. And then there's this other bucket of things like pain and GI things and GU things and mood and some of the behavioral and neurocognitive changes that can come along with neuromuscular disorders like Becker's and Duchenne. I'm going to pass it on to Leslie to talk about her role in physical therapy. Or sorry, Dr. Perlman, you're next.
That's okay. If you could advance the slide, please. So I, as a neurologist, I guess I have a little bit of name envy. We're only really just called neurologists, so there's not a lot of other terms floating around out there. And for myself, I'm a pediatric neurologist with really a focus on neuromuscular disease. And thinking about kind of neurologists out there and what our training backgrounds are, there's a lot of differences between who you might see in your individual clinic. For myself, I went through a pediatric neurology training pathway. And so for most people, that involves a pediatric internship and then a year of pediatric residency training. Then we do a year of adult neurology and 2 years of child neurology. In a lot of clinics, though, you might be seeing an adult neurologist. And so in those cases, that person would have done an intern year and 3 years of neurology residency with some exposure to pediatrics during that time. And then for the most part, for those of us that are neurologists who focus on neuromuscular diseases, for the most of us, depending upon when we trained, will have done a neuromuscular medicine fellowship. And for me, coming to the team at Seattle Children's, which is relatively recent, I just started there about a year ago, and I had come from a background in a couple of really great centers, but where there wasn't really a presence of rehabilitation medicine in those clinics. I did my training in St. Louis, primarily working with Ann Connolly, for any of you that know her, and then worked for quite some time at the University of Iowa with Kathy Matthews. And so I had to adapt a little bit and kind of really focus a little bit more in terms of what my role was going to be as a neurologist on this team, where really we were going to be partnered, where neurology and rehabilitation medicine were going to work closely together and really in tandem as we took care of patients with neuromuscular disorders. And so in kind of learning this different approach, and like Julie talked about, what neurology's role really is in a clinic that's structured like ours or like in Colorado, often we're one of the first people to encounter patients with neuromuscular disorders. And often neurology is really the setting in which patients get their diagnosis of whether it's Duchenne or Becker or SMA or some other neuromuscular disorder. And then that's often when we really get patients plugged into a bigger multidisciplinary clinic once we kind of know what that patient is dealing with and what's causing the problems that they're facing. And in that multidisciplinary clinic neurology, we tend to be more focused on the genetics of what's going on and kind of education about the disease process itself. We're often a lot more focused on the medical therapy aspect of trying to change the course of the disease if possible, and then monitoring how that disease is affecting not just the neuromuscular system, but kind of trying to help coordinate the other services that are involved and figuring out like which other specialists really need to be looped in and involved in an individual patient's care. And at least in our clinic structure, and this may change from setting to setting, the neurologist is often one of the main people that's involved in organizing and being a primary investigator for clinical trials and other research that's going on, and then recruiting any interested patients and families who may want to participate in these trials. So that sort of, from my end, has been a bit of a learning process, just because I came from centers where there wasn't really a rehabilitation medicine presence, and it was sort of the neurologist that filled obviously the neurologist role, but also took care of some of and many of the tasks that, as Jaclyn mentioned, in this clinic setting tend to fall under the purview of the rehabilitation specialist. So then we wanted to have Leslie talk a little bit about physical therapy's role within this kind of clinic environment. So if you could advance the slide, and I'll turn it over to Leslie.
Thank you. So as Terri mentioned, as physical therapists, we are trained in anatomy and physiology, in movement and rehabilitative sciences. We also get training on various common medical diagnoses. We graduate with either a master's or a doctorate in physical therapy, and other therapists have gone on and gotten advanced educational degrees, including PhDs. The American Physical Therapy Association supports specialty exams and certifications, as well as fellowships in pediatrics. However, there's no replacement for clinical experience, continuing education like these conferences, and keeping updated on research. And that's especially true when working with boys with DMD, because this area is changing so quickly. As Terri mentioned, my role in the clinic is to perform functional assessments like muscle testing, range of motion, gait assessment, the time performance tests, and things like the North Star. We use this information to make recommendations on stretching and exercise and physical activity. And like she explained, based on the natural history trials, we use the time performance tests to make appropriate recommendations for equipment and to set some expectation for near future motor function. The role of physical therapy has been influenced recently by the International Classification of Function, which has moved our focus from body structure towards increasing activity and participation. And as therapists, we've also played a role in research, especially with the performance of physical outcome measures used in the various sponsor-supported drug trials. The one difference, a strong difference between me and a physical medicine physician is that we are not licensed to make recommendations for medication or drugs. Next slide.
So similar to other clinic structures or Colorado structure, we have a very multidisciplinary big clinic that functions about once a month for our boys with Duchenne. And we also have smaller clinics where the sort of the heart of the clinic is the three providers that you see here. Oftentimes as children are traveling through their journey with muscular dystrophy, they're meeting Dr. Perlman first, and shortly after they're meeting myself and Leslie to come a part of the team and sort of join the journey. As I mentioned before, it's sort of simple to think about a cardiologist and a pulmonologist and what those doctors do in terms of body parts taken care of. And when it comes to sort of this patient-centered whole patient care, rehab, neurology, and physical therapy really interface and collaborate a lot. Some examples of that are deciding when to initiate steroids. The physical therapist may get some objective measurements. I may get some nice functional information about what life looks like out in the community. And then we're collaborating with Dr. Perlman to sort of make a decision on when that may be a good time to start. We're also making decisions together a lot of the time on equipment and bracing. And sometimes we are informing each other on some psychosocial things going on inside the home or in school that may impact a decision on treatment from Dr. Perlman. So there's a lot of nice objective examples of sort of what we do and how we all work together. I think the really nice thing about having a rehab provider and a neurology provider and a physical therapist all in sort of the same clinic space is it really allows us time to dive in with the families, learn their values, learn their priorities, and be able to go through this journey with them and keep those things at the forefront of our decision making to really make individualized decisions for all patients. Of course, following by the care guidelines as best as we can in doing that. And so I think that's a really great way, that our clinic functions. Next slide, please. And Dr. Perlman, I'll hand it back to you.
just like Julie talked about for their clinical environment in Colorado, here in Seattle, we have a pretty huge geographic area that we take care of. We often talk internally about the WWAMI region. So Washington, Wyoming, Alaska, Montana, and Idaho, all of these states, really, we're kind of the primary children's hospital for patients that live in these areas to come to. And so really making sure that our clinic is kind of one-stop shopping. It's an intense clinic day when patients come to that clinic and they see myself, they see Jacqueline, Leslie, and all the rest of the members of our team. But since a lot of these families are coming from so far, we want to make sure that that visit is really worthwhile and that we address all of these needs that they might have when they come and see us. And I think splitting things up between neuro and rehab, like we've been doing in our clinics and like this model sort of offers, is an important way that we can each sort of lend our focus and what our areas of expertise are to these patients' care and making sure that they get that care. I think it varies a lot across the country, though, in terms of sort of who the primary service is, whether it's neurology or rehabilitation medicine, that would run a clinic or be the primary person that's really kind of that central organizer of care for patients with muscular dystrophy. If you're in a center where it's primarily a rehab doctor or primarily a neurologist, it's not the case that there's something being missed or that there's parts of care that aren't being addressed that should be. I think it's really to the particulars of that individual clinic. And, different clinic setups and structures work in different settings. And there's not a right or wrong way for that to be approached. For us in Seattle, this model has been a great one that I really was fortunate enough to kind of fall into after Sue had been here for a long time and really helped develop this kind of clinic structure. So I'd have to send a thank you to you, Sue, for setting things up so nicely. But this has been, for us, a great model to work with and hopefully delivering great care for all the patients in these blue regions here on the map. So I think, that's kind of what we had to talk about from our end at Seattle Children's. And I think the next step, Rachel, I'll turn over to you for kind of the broader discussion.
Great. Thanks so much, Dr. Perlman and Dr. Omura, Leslie. I think that was incredibly insightful. Again, love to see how these different clinics model and integrate each of these disciplines together. So I look forward to a really great question and answer session coming up here in just a moment. Eric and Ryan, back to you.
Thank you so much, Rachel, and thank you, Dr. Omura and Perlman, and Leslie Vogel. Thank you for doing the one-on-one sessions with the families along with Claudia. They were just all thrilled. You're the best, and we can't thank you enough for putting in all that time with them. So we are going to open this up for full-on Q&A. And I think we're ready to go. We're going to pass this right back to you, lob it right back to you, Rachel. Take it away.
Just a little bit of technical volleyball back and forth, I suppose. So we've got a handful of questions that I think will be really great to kind of go through that have been coming in from the community. And I think where we will start, one of the questions that we received is, my center actually doesn't have rehab available in my multidisciplinary Duchenne clinic. Is that something that I should seek out, or are there certain questions that I should ask of my neurologist to kind of make sure that I'm getting the care that I need and that I'm covering all of those bases? And maybe Dr. Omura, we'll start with you on that.
Sure. As Dr. Perlman sort of alluded to at the end, I'm not necessarily sure that anything in particular would be missed by not having a rehab physician. I think that if their multidisciplinary team involves the neurologist and a physical therapist and an occupational therapist, some of the functional things that I may be trained in that Dr. Perlman and Dr. Parsons maybe didn't train as much in will be readily picked up by their physical therapist and by their occupational therapist. And that trio, the neurologist with the therapist, should be able to collaborate and figure out solutions and ways to have your child or you participate in the community and at home as you're wanting to.
I think that's great. Dr. Apkon, would you add anything to that?
Sure. As Dr. Omura said, there are some clinics that don't have a physical medicine and rehab specialist there. And the physical therapist in that setting usually is fairly independent. What I found that happens oftentimes is the PT is the one who identifies a need maybe to refer on to a rehab physician. And so that PT and the rehab physician work in collaboration. So that child, your child, who may not be in a clinic where there's a rehab doc, but the PT or the neurologist recognizes that need of that specific expertise, may refer you on to that specialist.
Fantastic. And I think the flip side of this question is really helpful too. I know we have a couple of centers, even within our CDCC network, where there's a really strong rehab presence, but there actually isn't a neurologist in clinic. So maybe Dr. Parsons, you can start off by answering the same question. What do we tell families? How do we guide families? How do we empower families that maybe don't have a neurologist at the ready on their Duchenne care team?
Yeah, I would agree with Dr. Apkon, actually, that I think that when there is an issue that arises where there's a question of perhaps a medical issue, a diagnostic issue, or a specific neurologic issue, that really the physiatrist recognize that, or orthopedists recognize that and say that they needed consultation. So I think that having someone who knows your child or knows you as an adult is really very helpful, because with that open communication, you always would have access to a specialist if you need them and have that referral be able to be made.
That's fantastic. Dr. Perlman, would you add anything to that?
Yeah, I mean, I would definitely echo that if there are things coming up that, if your child is in a center where it's primarily rehabilitation medicine specialists kind of organizing and managing their care, if there are things that they really feel like they need a neurologist input on, then sort of seeking that referral and having that kind of open discussion with them would be important. I think looking, at the centers that I've worked at or have talked to people from, I think that a lot of us are really adaptable, which I think is one of the great things, that in a lot of cases, as Dr. Apkon and Dr. Parsons had mentioned, that there may be places where it's a neurologist who's sort of filling, like, for example, in clinical trials, is filling that primary investigator role, and in other places, it's the rehabilitation specialist. And I think that fact illustrates the fact that just the overall care, a lot of us, can be very adaptable with. And you may not necessarily need a neurologist, depending upon the level of expertise and comfort that your rehabilitation specialist has in managing things like the medicines for Duchenne and the other aspects of care. It really, I think, is going to depend upon, like what Leslie mentioned, their experience and background, and kind of where their expertise lies and what areas they feel comfortable with managing as a care provider. And that's going to vary from center to center and from physician to physician. So I think assuming that, there are aspects of care that a neurologist wouldn't know what to do with or be comfortable with, or the flip side of that a rehabilitation specialist wouldn't quite know what to do with. It all depends on that person and their background and the clinic setting in which your child is being seen.
I think that's just so incredibly helpful to think about it from that angle. When I think about access to neurology, access to rehab care, multidisciplinary care, I think a lot about lifespan care and how needs change as people with Duchenne grow older and have different kinds of needs. Maybe Terri, you could start off and maybe give a little bit of insight about how needs change over the lifespan from a PT perspective, and then we can dive into a little bit about how that plays into neuro and rehab involvement as well.
Sure. I think you're absolutely correct that needs definitely change. I think in the beginning, when the children are very young, we're looking a lot at mobility. We're looking at joint mobility as well. And we're looking at function, and we're working really closely with the parents as well as the schools to make sure that they're providing for these. Some of these kids, it may be fairly invisible at that point, and the schools may not be aware that this child has issues. And I think it's our job to make sure that everyone on this child's team is aware of what might be issues. I think that as the child transitions from walking to a chair, that's another really important transition. And then I think that what we do as physical therapists is that's maybe in clinic, that may be our most important role. That based on natural history studies, we need to make sure that the family is aware of what they're going to need for that transition, what they're going to need in their home, what they're going to need in their school, what they're going to need for mobility. How are they going to get your sons from your house to the car? How are you going to get them to the grocery store? How are you going to get them to school? So I think that that's really a crucial, important stage that we need to look at, and changes what we do as well. We might not at that point be looking as much at orthotics and range of motion. We might be looking more at equipment. And then as the boys get older, we're looking at lots of things. We have a young adult clinic for our older Duchenne boys, young men. And in that clinic, we're looking a lot at pain. We're looking at nutrition. We're looking at pulmonary function. And what can we do to make sure that their quality of life is good? Maybe that is the stage where really, I think assistive technology is ultimately important. So Leslie, I'll let you comment as well.
I think on the other end of the spectrum, as we bring newborn screening in, the neurologist or the rehab medicine doctor may not have as much experience with infant movement. And in physical therapy, we spend quite a bit of time studying the various milestones that infants move through and what muscles are weak and how they move. And so I think that therapists can play a role in helping families decide if there's even a need for therapy if the newborn is functioning appropriately and is with good motor milestones. At that point in time, they might not need to get extra therapy. However, if they have developmental delays, then they would need to see a therapist for like a birth to 3 center. So I think we play a role at that end of the lifespan as well.
Yeah, I think it's just so important to consider how the presence of PT throughout the entire lifespan is incredibly important, but does change depending on, progression and age and all of those things. Dr. Parsons, would you add anything to this conversation specifically?
I think that there are a couple of other things to consider. So we're focusing on function and quality of life, but I think that we also need to focus on, for families, what is the natural history? What do we think about for the history? It's changing, but so that we are always doing anticipatory guidance about what the next step is. And part of that involves looking at transition. When we started 30 years ago, we did not have patients who were really living into their 30s and 40s, and things have changed a lot now. So we tend to start transition kinds of ideas from the time a child is around 12 and leading them through transition into adulthood. And part of that is, what are they going to be doing in terms of education, in terms of potential future jobs? The social and emotional issues are really hard around high school, I think. And so what kind of support can we offer to be able to incorporate our patients into the community so that they really do have a good quality of life and they're happy and able to actually live life the way they want? We had a great group of young adults who did the Friday night drinking club. And they had, one of the dads was a designated driver, and they went down and completely raided the downtown bars in Denver, which was fantastic. I mean, it was great. So, really anticipating things like that, I think, are really important as well.
That's great. And I love the downtown drinking club anecdote. That's fantastic. Dr. Omura, do you have any final thoughts on that question from the rehab perspective?
As a rehab doc, I think I would almost strongly advocate that as these young boys and men are getting older, there's a potentially an even bigger role for a rehab medicine physician to play as we're thinking about function. And as there are more limitations, how can we help these young men continue to participate in their communities, like going out with their buddies and having drinking clubs and things. And
I'm
also
not advocating the drinking, just saying.
Addressing those pain and nutrition issues that are coming up and really focusing on quality of life and that adaptive technology. So I would argue that as boys are turning into young men and men, that rehab and therapy role may become even bigger than it is when they're younger.
Just such great conversation and such great insight from each of you. And quite honestly, I wish we had some more time for conversation around this subject, because I think, keeping in mind the importance of all of these disciplines and how they come together to create, really fantastic, multidisciplinary, holistic, and well-rounded care is just so incredibly important. From there, I'll remind all of our viewers, if you only have one discipline or another, that's okay. I think that we've learned a lot about how to make the most of the care that you have if you don't have each of these disciplines available to you. And so I know that I myself have learned a lot, and I hope that everyone out there on the airwaves has learned a little bit too. So at this point, thank you so much to our teams from Seattle and Colorado. It's been an absolute pleasure having you, and we'll toss it back to Ryan and Eric in the studio.